Good afternoon, everybody. Welcome to this webinar, which is organized by ERA EDTA. And today you will hear about a webinar organized by the CKD-MBD working group. And the topic of today will be how to limit vascular calcification and treat calciphylaxis. My name is Vervloet. I'm the current chair of the CKD-MBD working group. I'm a nephrologist in Amsterdam, the Netherlands. And today we have a very nice panel. The speaker will be Smeeta Sinha from the UK. And then we will have two external panelists, which are Sandro Mazzeferro from Italy and Schurgers, all experts on vascular calcification. And I'm really looking forward to what we are about to hear in the next hour. Before we start, I would like to point out that if you attend this meeting live, you will earn one European credit for CME, which is always nice. And in addition, I will tell you how the format will be. So first we will listen to Smeeta Sinha. She will present about 30 minutes about the topic you see on your screen right now. And then we will have some 5 minutes input from each panelist. And during the entire presentations, you can pose questions in the Q&A box. In the end, we will have at least 10 minutes to address as many of these questions as we can handle. And I will promise you that we will wrap up in an hour from now. So let's not waste any more time, and we proceed to Smeeta Sinha.
Thank you very much. So I'm just going to get my slides up on screen, if that's okay. Okay, excellent. So those are my disclosures. Thank you so much, Mark, for the introduction. And let's see how we get on. It's already stopped working, typical. There we go, that's better. Okay, so those are my disclosures for you to all have a quick look through. And thank you for the topic of conversation. I'll be focusing on vascular calcification with a particular emphasis on calciphylaxis. And this is the outline of the talk today. So I'll very briefly talk through the pathophysiology and what KDIGO currently recommends before moving on to calciphylaxis, what we do at the moment, what we've learned from registries, and what clinical trials might be on the horizon. And I hope that perhaps I may be able to make a comment on how we limit vascular calcification and treat calciphylaxis. So patients with CKD have significantly increased cardiovascular morbidity and mortality compared to the general population. This has been known for a long time. It's strongly associated with cardiovascular mortality, particularly in patients on dialysis. And this is thought to occur from a combination of increased atherosclerotic disease as well as increased prevalence of medial artery calcification, so Munkeberg's calcification. We also know the degree of calcification correlates with that increased risk of cardiovascular events and death. But we are fortunate. There are a number of vascular calcification in vitro and in vivo models that have been established and allow us to study the pathophysiology. So looking at the prevalence, well, we have known for many years that calcification is an issue for patients with kidney disease, and it's prevalent in CKD 3 to 4, but by the time you get to patients who are prevalent on dialysis, you're looking at 83% as per the Treat to Goal data. And that correlates with mortality. So this is, again, old data from Gerard London's group, looking in 2003, where they looked at mortality associated with medial calcification or intimal calcification. You can see that all-cause survival, as well as cardiovascular survival, really does drop off. So what are the types of calcification? Well, there's the traditional Framingham risk associated calcification, which is linked in with atherosclerosis, so lipids, cholesterol, inflammation. There's medial calcification, which I'll spend a bit more time on today, and valvular calcification, which is, again, lipids and macrophage involvement. Calciphylaxis is a particular area of interest, although it's rare. It's caused by calcification within the medial wall of arterioles. So this is the kind of calcification you see in calciphylaxis and medial calcification. You start to get calcium within the middle of the wall, so it's circumferential rather than in a plaque. And you see this with age, absolutely, but a lot more common in patients with diabetes and end-stage renal disease. And when you look at autopsies, then you learn that it's not just deposition of calcium and phosphate. These cells are changing. And when you look at autopsies in plaques, you can even begin to see bone marrow formation. So it's ossification rather than just calcification alone. And we think this is because of what's happening to the cells. So this is just a schematic representation of a vessel wall, medial vessel wall. And you have smooth muscle cells in there, which are nice and elastic. But under certain circumstances, they can start to change their phenotype genetically. So in the presence of things like phosphate or calcium, those things you see in dialysis patients, they start to differentiate. So they lose their markers of so they lose their markers of a vessel, so reduce smooth muscle actin, and start to express markers of bone, so alkaline phosphatase. And then eventually they'll become like osteoblast cells and lay down a mineralized matrix. So why does that happen? Well, we naturally have inducers of calcification in the bone compartment and inhibitors that run through the vascular compartment. But in patients with vascular calcification, there's an imbalance. So we start to see more inducers and fewer inhibitors, which then shifts the balance. And largely we focused on phosphate because that's what we do in renal medicine. And this again is really old data. And part of the reason why we have focused so much on phosphate is because of observational data, which shows a clear linkage between mortality and high phosphate levels. But again, animal models have taught us a lot more. There's more to it than phosphate. So there's a protein called matrix GLA protein, and it's a naturally occurring inhibitor of vascular calcification. If you knock out the gene, you get widespread arterial calcification. And the GLA residues on MGP particularly bind to calcium, and they modulate these bone morphogenic proteins. And the really interesting thing about it is uncarboxylated MGP doesn't do very much, but to carboxylate it, you need vitamin K. And that's what's the active form. So you can see why vitamin K is of interest clinically. And if you look at this, if you look at data from the German registry, 51% of patients with calciphylaxis were on a vitamin K antagonist. So this has been shown in animal studies. You know, vitamin K induces calcification just as MGP knockout does as well. So it raises the prospects of MGP and vitamin K as a potential something that we can modulate for vascular calcification. It's already hit the markets. So vitamin K2 you can buy from Amazon if you want, and there's lots of natural health people out there who purport its benefits. It's naturally produced by bacteria and intestinal flora, and you can get it from a popular Japanese dish called natto. It's essentially fermented soybean. So as I said, the animal studies show interest, and certainly clinically it's becoming increasingly important. So if we were to summarize calcification, this is probably the slide that I'd use. So many different factors, repressors, ion imbalances, inflammation, oxidative stress, all these things. But eventually they all lead to hydroxyapatite, nucleation, progression of crystallization, and calcification. So how do we currently limit and treat vascular calcification? Well, let's look to KDIGO. So these are our experts. So KDIGO has a section on vascular calcification because it is an integral part of CKD-MBD, and it largely focuses on diagnosis and how we might identify it. There isn't really very much on actual management of vascular calcification, which reflects where we are. And there is a hint of it within the CKD-MBD management criteria for phosphate and maintaining calcium. So it talks about limiting calcium intake, but also lowering serum phosphate. But this evidence is, this evidence is not graded or 2C data, so not the strongest. Certainly not anything the cardiologist would be interested in from a calcification point of view. But I think we are learning and we are trying to test our assumptions. And there are two large trials currently recruiting. In fact, Hilo's completed recruiting, which are looking at phosphate targets. Is there any point lowering phosphate? If calcification is such a complex issue, why are we bothering? And does the lowering phosphate actually result in an improvement in outcomes? So I think the results of those trials will really help formulate not just what we do for phosphate management, but how that impacts on our treatment of vascular calcification. So I think How do we treat calcification at the moment? Well, we don't really. And how can we limit it? Well, based on, perhaps not the strongest evidence. So over the last 25 years, we have absolutely learned a lot about the pathophysiology, and I've not even gone into detail, there's so many. And there's likely to be an imbalance between inhibitors and inducers, but we've also identified potential markers of vascular calcification. And I'm hoping that one of our panelists will talk a little bit more about one of them in particular. And we've identified targets for the development of therapeutic agents. So hopefully over the next 10 years, we can translate that into effective strategies for actually managing calcification. And calciphylaxis is particularly unique because it's an extreme effect of vascular calcification. Those of you who've looked after a patient with calciphylaxis know how awful it is. And its rarity and disease severity has rendered it feasible to be designated as an orphan disease, so a disease which creates orphan indication for the testing of therapies. And that has introduced, that's been a real game changer, because it has opened up potential for companies to look at this as a disease area which is easier to, well, in theory, easier to study, but then opens up the market for wider vascular calcification. So can we start with calciphylaxis with a view to moving on to vascular calcification therapies? So calciphylaxis, well, a little bit of info on calciphylaxis for those of you who may not be familiar. It does predominantly affect patients with end-stage kidney disease. The epidemiology, or the reported prevalence and incidence, are really variable, from anywhere from 1 to 4% from a prevalence point of view. Incidence, German registry reported 0.04, and if we look at the EVOLVE study, it's lower, but that is a randomized control trial. So quite a bit of variation, which I think is probably related to variation in pickup diagnosis. But one thing that we do know is mortality is awful, reports of 60 to 80%. You do see it in non-uremic calciphylaxis though, but the association but the mortality is lower. So what does it look like? I'm sure you've all seen it, but I'll go through this. So you start with tender indurated plaques. It can look like libido. Some people can report that they can feel that the calcium deposits, but actually you're probably feeling the edema associated with the inflammation, which is associated with the deposition. You then start to get surrounding pallor or ecchymosis, and this is really when the pain is a hallmark of this disease, and you can get it at the early stage. By the time the lesion starts to ulcerate, it's quite late. So here are some of the pictures. This is calciphylaxis, but often missed because it looks fine, but it's only when you poke it that the patient jumps off the bed. So anything that looks like it shouldn't hurt, that does hurt, should probably start getting you thinking, what is it? And then this is the lesion as an example of the lesion as it can progressively break down. So you're starting to see that bruising, ecchymosis, and then you're starting to see early ulcer formation before tissue breakdown. And this can become circumferential, large necrotic lesions, which can ultimately lead to amputation or death. So I won't go into the pathophysiology of calciphylaxis too much because it's very similar to vascular calcification, but I would direct you towards this fantastic review, which was published in the New England Journal of Medicine in 2008, which it really is very comprehensive. Our understanding is that the pathophysiology of calciphylaxis is very similar to that seen in vascular calcification, but with perhaps a trigger that really expedites this process. We've learned quite a bit from registries, so I won't go through all the different registries, but here are some of them, in particular vitamin K antagonists. We've seen that from the German registry, Australian registry, work from the French group and in the UK. Obesity seems to be an issue. Dialysis, obviously, is a major issue, but there are some issues around phosphate, calcium and PTH. So the focus on CKD-MBD isn't necessarily wrong. There is a link there. So studies and registries are absolutely supported by the ERA-EDTA, and we hope that UCalNet will be up and running in a smoother, more streamlined manner shortly, making it easier to recruit into so we can continue to understand more about the disease So moving on to the calciphylaxis study data, I won't spend too long on here, but needless to say, in our data set, the majority were on hemodialysis with a preponderance of females with diabetes, but again, a significant proportion on warfarin. And we don't use that much warfarin in the UK. Lesions tend to be lower extremities, but also thighs and abdomen. And the resolution of skin lesions, poor, really poor. So this is included, this is all of them, hemo and non-hemo. 18.3% median wound healing at 6 months. So they're slow healing with high mortality. And when we looked at, what interventions do we do? Well, despite 66.6% of them being on STS, there didn't seem to be an obvious difference, but it's hard to, it's really hard to compare interventions on an observational study. So I hold that. But certainly low serum albumin and warfarin are associated. So what evidence-based management do we have? Well, this is what we do. Again, this is on the right-hand side, you can see a table which outlines what happens in the UK study, a mixture of things, multimodal. There is international variation, but largely focusing around what we can do with the dialysis frequency, changing calcium concentration, modulating the CKD-MBD parameters. So you'll see things like, calcium binders, some people Sinha, and then complication management, obviously antibiotics. But we do see off-label therapies, particularly if we look here at Sinha and Sodiumthiosulfate. They're used quite frequently. And what is this based on? Well, it's based on opinion. So we actually don't have any evidence-based management strategies for calciphylaxis. Sodium thiosulfate is extremely popular in the UK and internationally where it's available. There are numerous case reports, but there are no clinical trials. There have been attempts, but they haven't been successful. There has been a pilot study done in maintenance hemo patients, and there's been another study done recently in hemo patients, which has suggested potentially some benefits. So I don't think we can disregard it, but it would be nice to see a calciphylaxis study. We certainly don't know how much to give them for how long, and what do we do for patients with peritoneal dialysis. People have tried to look at this in a systematic review. So this is a systematic review from 2017. So they looked at loads of papers, 83 papers screened, 45 studies, but look at the volume, 36 case reports, 9 multi-case reports, 358 patients, but no RCTs. They found a high mortality, but interestingly, they reported a 70% success rate of sodium thiosulfate with lower mortality. But I think we're all aware of the challenges of publication bias. Nobody wants to publish your paper that says, I started a patient on sodium thiosulfate and it didn't work, goodbye. There is huge bias there. And also mortality has changed over time due to our improvements in the way we manage patients. So it's hard to compare data over many, many years. And they concluded that you can't do a randomized clinical trial in calciphylaxis. So continue doing registries. Fortunately, that has changed. So despite that, that wonderful data that you think STS is the way to go, actually our outcomes have not changed. So these are 2 Kaplan-Meier curves, one from 2001, and then this is from a study that was published recently in Journal of Nephrology from my group, and you can see the outcomes are absolutely dreadful. So whatever we're doing, it doesn't work. We did a propensity matched comparison, HD cohort versus calciphylaxis, and even with propensity matching, it was 67% versus 10.2%, 72 deaths per 100 patient years. With the wound complications that you expect, 1/3 of bacteremia, really low numbers of complete wound healing and high mortality. So I do think we need to look to clinical trial data, and the orphan drug designation has changed the landscape. If we go back to the first sort of if we're going to look at randomized controlled trial data, if you look at Evolve, so you will all know Evolve didn't meet its primary endpoint. There was a lot of crossover with commercial cinacalcet being used. So it didn't meet that endpoint, but a sub-study was published which looked at what happened to calciphylaxis. Now the numbers are small, but there were fewer cases of calciphylaxis in the cinacalcet arm than there were in the placebo arm. So, just a signal there that there might be something we can do. And then more recently, new drugs are starting to be developed. And this is probably the one that's most ahead, but there are potentially others. And this is a new drug. It's an intravenous formulation of a naturally occurring product called phytate, which is a natural inhibitor of calcification. And it's physiochemical. It doesn't interfere with calcium and phosphate. So if we go back to that original picture, it works here at the end. So it binds to hydroxyapatite on the surface, and it prevents further crystal progression and calcification via that route. So we did a phase 2 study. This is a few years ago. This was just a proof of concept. 14 patients were treated with SNF472. So these are patients with calciphylaxis, open label study, really just to see what it did. And we looked at wound healing. So this is 12 weeks. So we used a tool called BWAT, and you can see the Bates-Jensen Wound Assessment Tool Score reduced within 12 weeks in patients treated with the drug, pain reduced, and wound-associated quality of life improved as well. So they were promising results, but you have to be, you have to be really careful what you do with an open-label study. Even though it looked good, I mean, sometimes pictures can tell 1,000 words. If you can see here, this is within 12 weeks of treatment, the wounds were healing. And when you eyeball them, you can see the number of patients who had improvement increased, and this was significant. So that's led to a phase 3 clinical trial. So that is currently recruiting, and it's international, it has to be. And it's recruiting obviously in the US because that's where there's lots of patients, but in the UK and in Spain, and I know regulatory approvals are being sought for Germany as well as Poland and potentially the Czech Republic as well. And I think they are looking towards the Netherlands. So the more sites, the better really. So this will be probably coming to a site near you. And this is a phase 3 randomized placebo-controlled trial. Patients will go into screening and then they'll be randomized to receive study drug or placebo for 12 weeks. It was important that all patients got the drug at some point. So even if they receive placebo for the first 12 weeks, they will then get open label treatment for another 12 weeks, and then they'll be observed. So it's a 6-month treatment, IV infusion during hemodialysis. And the inclusion criteria are fairly straightforward. You just need to be on dialysis, hemodialysis specifically, and you need a diagnosis of calciphylaxis with an ulcerated lesion because we're looking at ulcers. In exclusion criteria, obviously people who are going to have a transplant or are unlikely to survive the duration. And the endpoints will be, it's an alternate endpoint, which was new for me, but it was approved by the regulators, probably because the relationship is so tight. So wound healing, again, measured by the BWAT, but a modified BWAT score, which is specific for calciphylaxis and pain. And then as well as that, it'll look at quality of life, looking at qualitative wound image review, because you don't want a statistically significant change if it's tiny and the lesion is still horrific. But also opioid use. And importantly, it's an IMP, so we need to understand the safety endpoints as well as the pharmacokinetics. But it's not the only trial. There are other clinical trials ongoing. This was a study that was presented at the ASN. I haven't seen it published yet, but what they presented at the time was, this is a group in the US. They did a 12-week phase 2 study, small numbers, again, 26 patients, but they treated them with phytomenadione, and they showed a significantly lower mortality rate compared with placebo, so 0% versus 31%. And if we go back to that pathophysiology that we've talked about, they significantly decreased levels of inactive MGP. So again, you've got the biological plausibility of why we might have seen those effects. There was one patient which experienced hepatic thrombosis, which is always an issue when people think about vitamin K. Whether it's clinically relevant needs to be established in a phase 3 study, which I understand is being planned. So what about vascular trial data for vascular calcification? Have we learned anything from the calciphylaxis studies? Well, I think the short answer is yes. After the phase 2 study was started, for calciphylaxis, the same company started a vascular calcification study. So in this, they're looking not at people with calciphylaxis, but patients with pre-existing coronary artery calcification. So patients had to have pre-existing CAC scores of 100 to 3,500 as measured by CT. no recent cardiovascular events, and on hemodialysis. And they were randomized to 300 or 600 milligrams of the study drug or placebo. And the primary endpoint was change in coronary artery calcification volume, with other calcification endpoints in there, as well as safety endpoints. And again, I won't spend too long in it in the interest of time, but the study was published in Circulation last year. Oh gosh, probably even, yeah, there you go, 2020, which is almost gone out of my memory. But this was a phase 2 randomized placebo-controlled trial which met its primary endpoint and showed a reduction in coronary artery calcium volume score, with 20% progression in the placebo arm and 11% in the treatment arm. The other thing that was of note, it was well tolerated. And this was despite patients receiving contemporary management for ESKD. So, you know, they weren't denied things like cinacalcet or non-calcium-based binders. So again, promise, it's a phase 2 study. We need a phase 3 to look at hard outcomes. But again, a drug that works in calciphylaxis or appears to work in calciphylaxis, showing again similar promise in calcification as a whole. And again, coming back to the vitamin K trials, I think that there's more work needed here, but people are very interested. There was a study called Valkyrie, which looked at vitamin K antagonists versus rivaroxaban plus 2 grams of vitamin K2, 3 times a week over 18 months. Again, we don't know what the exact dosing should be of these medications. I haven't given up on it. They didn't show that they showed that there was no difference in CAC, thoracic aortic or cardiac valve calcium scores, and no difference in cardiovascular events. But there is another study which looked at oral vitamin K2 in 52 patients on dialysis, and they had lower uncarboxylated MGP levels, but sadly no difference in aortic calcification at 1 year. The VitaVasc-K study, I understand, has been terminated before completion, but I'm not entirely sure why that is. IPAC HD, again, looking at vitamin K versus placebo, that's got a vascular calcification outcome measure that's been recruiting since 2012. You know, these studies aren't easy. And there's a newer study which has started looking at 200 HD patients, looking at oral vitamin K thrice weekly over 18 months, again, looking at calcification. So I think there is going to be more that we see around the vitamin K space as we move forward. The other thing that's of interest is magnesium. So magnesium, you know, if we're looking at that end hydroxyapatite, that end prevention of hydroxyapatite progression and nucleation, magnesium is a really potent inhibitor of vascular calcification. So people have looked at the role of increasing magnesium in the dialysate just for 28 days, and that increased T50 score. So suggesting that it's having a physiological effect within the blood compartment. People have looked at it in CKD, so trying to get there before patients end up on dialysis. And this was a CKD 3 to 4 2-year open label study. And again, some promise. Look at this, an improvement in coronary artery calcification, 11.3% versus 39.5%. Magnesium gives you diarrhea, so unsurprisingly quite a high withdrawal rate, but you know, not as bad as I'd have thought. Magical CKD, another study looking at a placebo-controlled RCT in CKD patients over 12 months. Sadly, no HD studies ongoing, at least on clinicaltrials.gov, but I'm sure we'll start to see more of that coming out over the next few years. So if I were to wrap up, so focusing on calciphylaxis, usually seen in end-stage kidney disease and characterized by really painful cutaneous non-healing ulcers with a high mortality. That summarizes calciphylaxis. Our management is opinion-based, and we need to acknowledge that what we're doing is based on you know, what isn't great, but multimodal, and we try our best to deal with the multiple factors at play. Calciphylaxis registries and studies have been key to driving our learning forward, and not just for calciphylaxis, but for calcification. So I really would encourage you, depending on where you're based, to look at UCalNet, and if you're in the UK, at the UK Calciphylaxis study, which is still running. But also start looking at clinical trials. They have started, and there's going to be more coming. So particularly for calciphylaxis, The Calcifix trial is going to be Europe-wide. Absolutely look into that, but get your patients involved, because those calciphylaxis clinical trials are also likely to be forerunners for CTIM. So those new drugs, the new ones, rather than repurposing old drugs that we've always used. So in summary, how do we limit and treat vascular calcification? Well, I actually don't know, but I think that's going to change. And I think for the time being, we just carry on as we are, as best as we can, based on the toolkits that we have, which are treating their individual risk factors as best as we can. So thank you very much. And I'd just like to acknowledge my team. This is clearly pre-COVID, because we're not allowed to do that anymore, but also Vincent Brandenburg, who helped loads with the German registry side of things, the EREDTA, and Sanifet for allowing me to use some of their slides. I think I'm on time.
Thank you very much, Smeeta. You're perfectly on time. And thanks for this very nice condensed overview on which you could have talked for 2 hours, I guess. Thank you very much. I noticed there are some questions coming in, but as I told you, we will address them all if we have the time to, but we'll do so after the comments on what you told us and the additions by the panelists. So for the participants, don't worry, we will come back to your questions, and don't hesitate to post even more, because we are a few minutes ahead of time. First, I'll give the microphone. Well, actually, it's his own microphone, but I'll give the word to Sandro Mazzeferro from Rome. So, Sandro, please comment.
Okay, thank you, Smeeta. Very nice presentation. And what I'm worried about is reaching a diagnosis. Frequently, it happens to me that the colleagues ask me help to decide for a diagnosis. This means that there has been time that has been lost before deciding the true diagnosis. So I'm afraid it is not so straightforward to for a nephrologist to make a diagnosis of calciphylaxis. And I think that when the things are dramatic, when pictures are clearly evident, there is no doubt. But in the very early phases, it is much more difficult. So I think that there are 2 points that you should try to underline. How to reach an earlier diagnosis as early as possible, and if it is necessary, to develop a team of specialists that can congregate, can join in order to reach the diagnosis as early as possible.
Yeah, absolutely. Without the diagnosis, we can't do anything else, never mind recruit them into a clinical trial. Yeah, it's so difficult as well. And the knowledge is so variable. I think part of it is because the lesions in the early stages look so harmless. They're just a little, blobs, just a little bit of purple. So people don't really think of calciphylaxis until it breaks down, as you've said. I think this is where education of our nursing teams is probably going to be more useful, because the patients will talk to the nurses and say, I've got severe pain, so they can then pass it on to the nephrologist. But yeah, I mean, for us in the UK, and I certainly know in the US as well, they have specialist clinics. So even if you have a suspicion, we have a joint service with a dermatologist or a wound specialist. So my clinic is a wound specialist, dermatologist with me, and we also have a dedicated histopathologist, so that if there's any diagnostic uncertainty, we're not afraid to do a skin biopsy. A skin biopsy isn't going to be diagnostic, it never is, but if you're not sure, it can be helpful in differentiating other things like pyoderma gangrenosum, for example. So it can be helpful, but I completely agree. And yeah, I probably need to make sure there's more of a focus on the diagnosis bit to start with, but hopefully that will improve over time.
Well, I was wondering if we should not try to develop a risk score for dialysis patients so that we can perform periodically a physical examination, in particular of the lower extremities, searching for possible nodular early lesions that could be the starting point of calciphylaxis. What do you think about this?
Yeah, I think it's difficult, isn't it? Because our patients have so many wound lesions, particularly distally, with them because they do still have atherosclerotic peripheral vascular disease as well, but it does look quite different. Classically, calciphylaxis is sort of on the adipose tissue, so the upper thighs, but as you know, we do see it lower down as well. People have tried to do scores based on clinical features and biopsies. The problem is it's rare. So to do a regular assessment on something that's rare, I'm not sure how much buy-in we'll get. I think it's a great idea, but because I suspect those risk factors for calciphylaxis will also be risk factors for vascular calcification. So if we addressed vascular calcification and identified that and treated that, we may never see calciphylaxis again, hopefully.
Last thing, a curiosity. I've always been curious of knowing if by administering antibiotics to our patients, especially if they are assuming some warfarin, could represent a final starting point for the development of calciphylaxis. And so my question is if we should not supplement vitamin K anytime we treat our warfarin patients with antibiotics.
I guess I'd probably say, should we be treating our patients with warfarin in the first place? But that's a whole different conversation.
But there are so many that are treated inevitably, it seems.
Yeah, exactly. It is so difficult, and so I don't put my dialysis patients on warfarin. But again, yeah, that's probably a different conversation. But what I'm hoping is we'll learn more about vascular calcification, particularly work that I'm hoping we'll hear a little bit more from our other panelists, that we'll start to understand what's causing it, vascular calcification. Whether we supplement with vitamin K, I'm really excited by the vitamin K story. I know that some of the studies have been a little bit disappointing, but it makes sense. It's cheap. It seems harmless. I'd really like to see a really good trial done there, looking at different sort of indications. The Valkyrie study was particularly interesting because it looked at vitamin K, then a NOAC, and adding in vitamin K. I'm not saying a no to it at the moment. I think there may be some things we can do around that area. But I agree with you, Sandro. The option of adding in a vitamin K, who knows? With the question around antibiotics, I think there's a bit of confounding potentially, because calciphylaxis is thought to be a two-hit process. So you have a predisposition and then something happens to you and that's what triggers it. And if we look at again, observational data, but these patients tend to be hypoalbuminemic. They tend to have high inflammation. So it may be that actually it's the infection that then has an effect on naturally occurring inhibitors like fetuin. So it's a negative acute phase protein, which then triggers it. This is all speculative based on lab stuff. But it may be that the antibiotics are there to treat the infection and maybe don't have an impact on the actual development of calciphylaxis. Who knows? Lots of interesting questions there.
I think this might be the ideal moment when talking about the role of the microbiome and vitamin K to move over to Leon. And I need to proceed because in addition, we have a lot of interesting questions which I would love to address as well. So first, your mic's on, please, Leon.
Thank you, Mark, and thank you, Smeeta, for this wonderful presentation. And always, if I see all the data together, then I get intrigued and enthusiastic and energetic of working with vitamin K and warfarin and calciphylaxis and vascular calcification. But also in a time of COVID, you have a lot of time to think. And I wondered in the past time whether or not you as a clinician also see similarities between the disease COVID, where you have a small vessel disease, where you end up with small thrombi. And actually that is more or less the same as what we see in calciphylaxis. And you nicely showed that the medial calcification is present in calciphylaxis, yet we also see the microthrombi. And that actually triggers me, because what we do is we give these patients warfarin. At least some 30 to 50% of the calciphylaxis patients are on warfarin, yet they still develop thrombi. So do you have any idea what is the chicken and the egg? Is there first calcification, stiffer vessels, thrombi, or is there some underlying thrombotic consequence that is also leading to calciphylaxis?
Yeah, so in I don't think it was on my risk factors slide, but if you look at non-uremic calciphylaxis, you see coagulation disorders as risk factors, and you can see aberrations in, for example, protein C and S. I mean, this is the cardiologist would laugh at me talking like this. This isn't strong data, but these are just signals that we might get. So yeah, absolutely. I think thrombosis is a factor. How much, I don't know. What we classically thought is that you get the medial calcification, which is a pro-inflammatory process, which leads to then intimal proliferation, subsequent fibrosis and necrosis, and then you get thrombi, so almost like an atherosclerotic plaque. So the disease process happens first and the thrombosis happens later. But I don't think we know enough about it to say that definitively, particularly when you look at the non-renal patients. So I do think that thrombosis has an element and maybe a risk factor.
Yeah, and you're absolutely right, because protein S in particular, if you are protein S deficient and you give patients warfarin, you end up with a lot of skin lesions. And protein S is one of also these vitamin K dependent proteins that is affected by warfarin. But actually we never really look at it. We only focus on MGP, and maybe we have to broaden our view in also coagulation and then relate it to vitamin K dependent proteins.
That's a really good point. I hadn't really thought of it like that. We're so obsessed with MGP that, you forget that vitamin K, gamma carboxylates, several other things, and certainly that link with anticoagulation. Yeah, it's a really interesting point. Definitely worth pursuing.
Yeah, and also want to know your thoughts of if you do intervention trials. Everybody has, of course, his specific target. And for me, that's vitamin K and MGP and vitamin K dependent proteins. Others have magnesium, and we have many of these treatments. What do you think of having combinations of these treatments? Because that is how we, in the past, started to treat calciphylaxis. Throw in everything we have on the shelf because, well, we try to rescue our patient. But nowadays, we become more specific. And I'm aware of trials where we give, for example, vitamin K. It was not always 100% helpful. But the combination of, for example, vitamin K and phosphate binders, influenced each other and had a better outcome than one of the standalones.
Oh, fantastic question, and really relevant, because if we think about what we've learned from COVID, if we look at the recovery trial, that's a platform trial, isn't it? Where somebody goes into one, if it doesn't work, you move into the next, if that doesn't work, so you can try combinations. I think it's in the public domain. Yes, it is. So in Australia, they have started to develop a platform trial for calciphylaxis. And it's in its early stages. Grant funding is there to develop it. And the hope is that that will be a multinational platform trial where we'll look at multiple interventions. So not just drugs. Actually, what about dialysis frequency? What about cinacalcit, although that's a drug, but what about different dialysis membranes? So we have the Theranova membrane, which they talk about reducing inflammation. So yeah, I think that is eventually the way we'll go. And I think COVID actually was really helpful there because it showed us that we can do these trials and we can do them rapidly. Might take a bit longer with a rare disease, but if we do that internationally with buy-in, it's also more attractive to patients. You're not going into a study for one treatment. You have the option of moving in between different treatments if it doesn't necessarily work with you. I think that's still a little while down the line, but again, in the next year or two, hopefully we'll hear more about that style of study design.
Yeah, and especially bringing expertises together, I think that is the way to go. So I think, considering time, Mark, I think I hand the microphone back to you.
Yes, because we have some excellent questions from the attendees, which I would love to bring to your attention too. And I will ask you, Smeeta, if possible, to be a bit concise, because then we can handle all of them. Some of them are connected to parts we already discussed. So the first one is that you mentioned that dialysis modality or dialysis technique might have impact on the evolution of calciphylaxis. So what do you mean about it? This is a question from Alexander Kirsch.
Yeah, so if the Calciphylaxis registry study has been going on over sort of 12 years. We do a lot more home therapies now. We do more, we do 4 hours instead of 2 to 3 hours. Some people would be allowed to do that. We also use more high flux HD, or we use HDF. So it's those kind of developments.
Yes. You also mentioned, I guess, that being on PD is a risk factor.
Yeah, so I don't know about that, if I'm honest. It might be. I think when we look at the reason why people say that, it comes from a big data set from Canada, but they had a high use of calcium binders, calcium-based binders. So there's some confounding there. I think we need to look at that in a little bit more detail. They're not overly represented in the registries.
So one way, this is a question from, I don't know, but there is a question, if you do short, frequent dialysis, would you adapt the dose of sodium thiosulfate, for instance, to 12.5 grams if you give it 6 times a week?
I would suggest people put people into clinical trials. It's really difficult to make recommendations based on no evidence. The sodium thiosulfate is rapidly dialyzed out, so it's highly water soluble. So the minute you start the next dialysis, it will be gone. So it depends on whether you want exposure frequently or if you want it less frequently but for longer. So I don't know the answer to that. We tend to just use it 3 times a week because that's what people have done historically. But if there was a trial, I'd put the patient in the trial.
Yeah. Okay, thank you. So the next questions come back to the discussion we had on the use of warfarin. And this is related to a patient of Ivica Horvatich. So she mentioned there was a patient who had an ischemic stroke following atrial fibrillation. Would you keep such a patient on warfarin? And I remember several presentations by Jürgen Flöge, in which he told us that he would never give warfarin in a patient on atrial fibrillation. But here we are discussing secondary prophylaxis. So a patient with atrial fibrillation and an ischemic stroke.
Who wants to take that one? Shall I take it? I'll make it concise. I don't use it. I wouldn't recommend it. And if we look at the US, there are NOACs available, and there are studies ongoing again, looking at not just primary prevention, but secondary prevention. And also, why do our patients get stroke? Are we confident it's exactly the same reason as the general population? Our patients were excluded from those trials. So before we draw conclusions, we need to go back to the core data. NOAC, if you must, a NOAC.
Okay. And Sandro, you as a clinician, do you use warfarin in any of your patients?
Well, I think when it is necessary, there is a fight with the cardiologist, and in the end, we decide. Everybody puts its reasoning, and in the end, there is a solution for the patient. I'm not sure that is the best solution for the patient, but that's a solution. I just remember a recent fighting with a colleague. I wanted to stop warfarin in that case, and he wanted to continue that. But it may be the reverse.
Well, I have the same issue. So I usually want to stop warfarin and all, but then I have a fight with the cardiologist and the neurologist. Okay, so I hope this is an answer to the question. And we have two questions from Mehmet Kambay. I'm happy you're here, Mehmet, and it's unfortunately you cannot talk back to me. I'm looking forward to the day that we meet again. And Mehmet is coming back to the role of magnesium as a phosphate binder, because if you use magnesium as phosphate binder, you do, well, actually you do two things by one compound. So Smeeta, what do you think about it?
Yeah, so anything, I believe that calcium loading is not a good thing. So anything that avoids excess calcium loading, I think is beneficial. And I do like the magnesium story. I'd like to see a trial. I'm going to say the same thing again and again and again.
Yeah, and the second question from Mehmet also covers well what we mentioned, the multi-target treatment. So why not using adequate phosphate binding with magnesium and in addition provide vitamin K supplementation?
Exactly, and I think this comes back to what Leon was suggesting, but also the day-to-day clinical challenges that Sandro has dealing with all the different problems that they have. I think that's the reality of life, and we need to study that in these new platform trials that are available, that should be coming available.
Okay, then we have one question from Maria Gonzalez. Well, which is about hyperbaric oxygen. In my country, we have two sites where we have hyperbaric oxygen, as far as I know, and one of these sites is mine. But these are also the only places where sometimes this therapy is used. What can you tell us about it?
So there's lots of potential benefits of hyperbaric oxygen. You know, it's bactericidal, so I didn't know this until I started learning about calciphylaxis. It also supports wound healing and infection healing. So, you know, there are good wound reasons to put people on it. And it, you know, from an ischemia point of view, because calciphylaxis is essentially an ischemic condition, you can see value there. It's not going to address the root cause of the problem. And again, it's one of those, can your patients actually sit in a hyperbaric chamber for prolonged periods? Because it's not as easy as it sounds.
Yes, thank you. Then we have one question about the local use of sodium thiosulfate. Have you any experience using it locally?
So we don't use it. I don't know if Sandro's group uses it, but we don't use it. But there have been case reports about topical application of STS. Again, case reports, so you have to be mindful about how to interpret those.
Sandro, any comments?
No, I do not use sodium thiosulfate locally. My caution when using sodium thiosulfate is watching at the anion gap after using frequently in order to have an idea on the reached level of the drug, even though it is dialyzed quickly, but it may be helpful in order to avoid excessive exposure. But if I can say, I think that when I have a patient with calciphylaxis, I use every therapy that is recommended, because the outcome is so worrying, okay?
Yes, I completely agree. And this also brings us to the question from Emmanuel Zitt. Hello, Emmanuel from Austria. And we already discussed about the potential role of NOACs. And Leon addressed the issue that the occlusion of small arteries may be driven by microthrombi. So why not using rivaroxaban or any NOAC in preventing that? And this brings to memory a publication by Carmine Zoccali, I think in the American Journal of Nephrology a few years ago, in which it was reported that patients who used, I think it was apixaban, but I'm not sure if it was, that they apparently did better. So what would you answer to Emmanuel about the role of rivaroxaban as a treatment?
Yeah, so these are largely hemodialysis patients. So if we're looking at drugs that you can use, apixaban is probably the only one that's got a license, certainly in the US. Again, no studies have been done, but again, biological plausibility sits there. It's not going to address the underlying disorder. And I think we need to start looking at what the pathophysiology of the condition is and target those and the individual. But as you've said, we're also humans rather than just scientists. We just throw everything that we can at the patient. I think apixaban or any of the NOACs haven't featured as treatment strategies, probably because of a lack of experience of them in general, rather than us not trying them.
Yeah, well, I personally do use rivaroxaban or apixaban. Actually, in the approach as Sandro mentioned, I try to do anything I'm aware of what might help. And apparently it's not doing too much harm. At least that's what I hope. So another question from Alexander Kirsch. Are you reluctant to use IV iron? So is there a pathophysiological role of IV iron in patients at risk for calciphylaxis?
So I'm not concerned at all, but I have seen, and it will be published soon, but I've seen data from Pivotal, which was the high iron versus low iron study. And there was no difference in calciphylaxis incidence in there. And then if we look at the evolved data, there were patients in there who were being treated with iron and not treated with iron, or in a large cohort, nothing really flagged there. This is again looking at iron deposition within tissues of patients with calciphylaxis, but you also see iron deposition in tissues of people who don't have calciphylaxis. You see it in legs, hemosiderin deposition in chronic eczema. You know, is this pathological? Probably not, but you know, even if it is, we know that there is harm from not giving people, maintaining people's hemoglobin on dialysis. So do you want to give them back-to-back infusions, or do you want to try and manage their anemia? So I do not stop iron.
Okay. So I usually am curious about or amazed by the fact that we, on the one hand, have vascular calcification of large arteries, and we have calciphylaxis, which are the smallest arteries, and these seem to be two completely different compartments of the arterial tree. Are these different diseases, and are patients who have extensive central vascular calcification, are they at risk for calciphylaxis?
It's hard because the prevalence of vascular calcification is so high in hemodialysis patients. They, you know, most of them will invariably have it, but you do see patients who don't have large vessel vascular calcification develop calciphylaxis, and that might be because their pathophysiology is slightly different, and it may be that they have more of that thrombotic phenotype or other risk factors, who knows. But I know that UCalNet will be looking at the genotyping of patients with calciphylaxis as well, which is different to previous UCalNet collections. So, you know, if people recruit their patients into that, then there's an opportunity for us to learn a little bit more about risk factors from a genetic genotyping point of view.
Okay, thank you very much. If you have any questions left, Sandro or Leon, I give you the opportunity to do so now for 30 seconds. If not, then I will start by wrapping up. First of all, by thanking Smeeta for this wonderful presentation and addressing all these difficult but important questions, and also by the important contribution from Leon Schurgers and Sandro Mazzeferro. I think this was really wonderful. Thank you so much. And then for the attendees, I would like to ask you to complete the survey, the questionnaire, which will follow. This will help us to improve for next webinars organized by ERA EDTA. And in addition, I would like to announce the next e-webinar organized by ERA EDTA, which is done by the Eureka working group. And this will be on assessing fluid status in dialysis. Is lung ultrasound the emerging gold standard? Something many of us might not use, but this might change. So this e-webinar will be organized on March 4. Thanks again. I think this was a wonderful webinar, and I promise to wrap up in time so you can all go to your dinner, and I hope you enjoy your evening. Bye-bye.